so we'll go over assessing dermatomes and the dermatome level that you want. Occasionally they'll have a PCA as well. Do you guys call them PCAs? Patient controlled? Okay. Occasionally they'll have that as well if they didn't think they got a very good block with the epidural, or if there's a lot of pain in the recovery room, or if they didn't get a block at all with the epidural, which you really hope your nuss patient gets a good block. But sometimes they'll have PCA, and then they'll start oral pain medications as soon as they can start eating, usually around like day 30-ish. Incentive spirometer is extremely important post-operatively. They'll have a Foley catheter until they're off of the epidural and the PCA. So you want to make sure you leave it in until those are gone. And then they do not like to lie flat in the bed. If you can imagine having chest surgery and then lying flat. So they like to be sitting upright in bed.
High followers.
Yeah.
Yeah, or even, I mean, semi-flowers even,
Yeah, that's fine. And then discharge is usually in about 5 days post-op. And they have to be able to be up and walking and taking PO pain meds, tolerating them. And then they can resume regular activities in about 6 weeks. And the bar stays in for 2 to 3 years, and then it's removed.
And it's an outpatient surgery,
Yeah.
right, with the removal?
Yep, it's outpatient, so they get to go home the same day, and their chest stays intact. And the other really important thing post-op is that they need to have a chest x-ray before discharge. So before discharge, have the chest x-ray done. He has that in his admitting orders. For nurses, if you can have that chest x-ray done before he comes to the floor post-op, the last day that you think they're going home, send them for their x-ray ahead of time, then he can look at the x-ray and know if the patient can be discharged or not. It's just to verify that the bar is in the right place still and everything looks good. And so if you can, to help your families to be discharged, have them get their x-ray the day before discharge even, then you can look at it when he comes in.
And one of the things I don't know on there, but the turning.
Oh yeah, we'll do,
Okay.
we're gonna do all
Okay.
that. So then we have these handouts. Renata was gonna go over the handouts, and then we'll give you like a little nursing demo.
Okay, I just want to be in that handouts what we were giving to you. This is like really like an overview of all those 5 days, like in bullets, what you should expect the first day, second, third, and the fourth, and prior to discharge. Over here, there's another one what we're gonna go over as well for the dermatome levels. And we did put it here. This handout, the patients are getting it pre-operatively as well from Jackie, that way they will know what to expect as well.
They couldn't get that education ahead of time. These patients are
And it
prepped
is
for this
important.
surgery, and they know what to expect from the surgery, and so they know their pathway of where they're supposed to be for discharge and what's expected of them, and they get all this information as well, pre-operatively.
But we would like to go with the day now, pretty much like day 1, day 2, 3, 4, and 5, and let you to discuss to have any questions and stuff, okay? That day number 1, the post-op, they are usually in a PACU in a recovery room like for an hour, hour and a half. It depends if they are able to manage their pain or not. They are on epidural infusions, and if the pain is not very well controlled or the epidural is not working properly, they might come with the PCA as well. That way, when you gonna get the nuss patients, you want us to have the room ready as well. How we said, they are coming with a Foley, you need to have a monitors, the cardiac whole set monitor on. To have a suction, oxygen is very common that they might require the half a liter just to, because they are taking a very shallow breath, that they might, when they are asleep, deeping down like those 88, 89. That way nasal cannula available as well. And first, regular post-op, the care, I don't know what's your requirement, but we usually have it half an hour hourly, and with the pictures first 12 hours are every 2 hours, the vital signs and a full assessment. With the epidural, you are actually assessing, there is two kinds. There is medicine for the pain relief and a medicine to numb the chest. That way reasoning, because of the numbing chest, that's where the most of the movement, was. That's the reason we wanted to have it numb. And that caused the dermatome levels that you need to assess as well every 4 hours. And there is the grid. And you're really shooting for the T4, like right here above the nipples, up to T6, T7, the end of the ribs, okay? If for some reason you do assessing, and we're gonna show it to you what to take the steps, and you see that they are numb, up high, that go ahead and stop the infusion, call the pain service, because sometimes with the positioning and everything, the rate can be too high and it can stop the breathing and to affect the breathing as well. Okay, that way it's very important to assess the patient.
So we can't titrate down, we have to call pain service?
I would, because the epidural infusion stays in the system for an hour. That way it's okay to turn it off. Don't be aware all of a sudden they're gonna be in a lot of pain. You still have a lot of, the time. I'd rather to be safe, turning it off, call the pain service. You can always give the breakthrough dose if the pain is going, in a 15 minutes, 10 minutes
And
down and stuff.
Just to add to that, because I know specifically what patient she's talking about, you always want to look at the patient too.
Mm-hmm.
So if the patient's alert, arousal,
Yeah, then that's
all
fine.
that stuff, then
Yeah.
titrating would be appropriate as well.
Okay.
If you're
Or
continuing
minimal
to
rate
watch.
it, put it down. If it's running at 12, put it down to 5 and call pain service.
Oh, okay, so drop it down that much.
Drop it down and call pain service.
Okay.
And it's really if you forget, I can't remember if it's 3, dermatome level 4, 5, what is it? I can't think. Just look at the nipple line. Where's the nipple line? If it's above nipple line, it's too high, they're getting too much. If they can't feel up here, they can't feel their chest, they can't feel their shoulders, they can't feel their arms, they're getting too much. You have to act really quickly, because they could have epidural toxicity.
Yeah, and other the epidural toxicity, the part that it's numbing, they can get toxic, and usually the symptoms are, the low blood pressure, they have a metal taste in the mouth. You can see the droopy eyes as well, or unequal the pupils too. Anything between for that day 1. Day 1, all the way up to pretty much the half of the day 2, it really is only the quiet time, resting as much as possible, and really your goal is the pain management, having them comfortable as possible. They do, because you can imagine how they were in an OR for multiple hours. We do position them very slightly though to the sides. That way most of the movements is pretty much from the waist down. And for the chest, really like a one pillow. That way with the draw sheet, you just do lifting and the other person just kind of popping it in. Nothing like this to the side. You are trying to avoid the direct pressure on the sides of the chest because of the tissue, the damage and what the trauma went on. And the other thing, is just so giving the time for the healing. But
And the
you have to
repositioning
every
is
2
for
hours.
the epidural infusion, so that it goes up and down the spine and infusions evenly, so they get a nice even block. And then also, of course, for pressure source. So you want to reposition, and I really stress saying reposition, because if you tell them you're going to turn them, they're gonna look at you like, get out of my room. I am not turning anywhere right now. My chest hurts so badly. So you really wanna say, I'm gonna gently reposition you right now for comfort. It makes a big difference than saying, I'm gonna turn you, because
You have alcohol, right? Usually, even the pain service comes and once a day they do assess. you actually do not have a pain service, right?
Buildings and pharmacies.
They have some pharmacy, but I don't think they're.
Well, we do at the children's, the pain service
Anesthesia is
comes-
following
yeah.
closely, yeah.
All right.
Okay.
Yeah, and they use an ice cube.
Oh,
But you
Or
can use an
whatever,
alcohol
yeah,
swab
some of
and
them
ice
the
cube.
scratching
Yeah.
or the alcohol.
yeah,
right?
scratching works.
Yeah, that they, what we do when we find out that the alcohols, of course, they should not be in a pocket warm. Yeah, that they just opening it up and trying to tell, which the first day is very hard. They are so drowsy and you really need to make, that they are able to communicate with you. That way, it's very common that you actually start in your mouth. Dana, I'm just gonna assess your dermatome levels. I'm gonna go from up of your shoulders, which are you gonna feel the normal, and I'll go across your chest, and you tell me when it starts feeling different, and when you feel again as you have it on your up the arm. Okay, that way I'll just go. I'm gonna start here. That feels normal. How about here?
My arm, yes.
Okay, and I'll go across and down. Tell me when it starts different.
Yeah, I can feel that.
Okay, you can still feel like this, still the same.
Mhm.
How about here?
No, it feels a little different.
Okay,
It's
and
not
then-
really numb, but it feels a little different.
Good, that's okay. That's where your blood starting, okay? It doesn't have to be necessarily like numb all the way. There you go, cross and tell me when it feels the same,
No, I
like
can't feel that.
Still cannot feel it? All right, then we are in trouble. Can you still feel this one? All right. If she would continue, say, oh, I still cannot feel it, that means, again, it's not only up, but it could be the down way as well. That's why we are doing the neuro checks really as well with the legs. And I'll tell you the one time actually we got case that around the incision of the epidural incision, there was the fluid collection. And unfortunately, it was the patient who was complaining about little tiny things to the point that everybody, whatever the complaints, kind of like the nurses shut down and, oh, he's complaining again. That way I got it, from the night nurse, he's saying that he doesn't feel his legs, and everything. I'm like, wait a minute. Like, really? Or, no, yeah, I assess him and everything. I think he's just, being whatever. That way, I actually didn't got it. I just went up. It was during the report. And be there, and I did not tell him anything, and I really, squeezed his toes, and he did not flinch at all. That way, I called the pain service and everything, but what I wanted to tell, there was the fluid collection and an insertion, and it was actually pressing on his, the spine and everything. He needed to have actually the start MRI and actually take for lumpectomy, because how much, he was numb from the waist down. He recovered and everything, nothing else happened, but I know because we do have a patients and everything, sometimes they can be, because they are in so much pain, and can be very, never always pay attention what they are really telling you. That way, if that's the case, again, slow it down, call the pain service for help, just to reassess where we are.
You want
And
the block
this-
to really be right about here.
Yeah.
And
And
you
I
can
just
start with moving your legs, can you move your feet, can you wiggle your toes, can you move your hands, then at least you know that they can do all that.
And the same you do on the other side, and it could be that she can tell me, no, I don't feel, it can be even patchy, or just a very narrow. That way, that's the reason what Dana was telling me is very important of the positioning. That way, what you wanted, if this side is less coverage, just moving them to that direction. Hopefully, the catheter or the medicine will go to that side. Okay, any questions regarding that? That way, we are doing that every 4 hours, and usually pain service does it in the morning by themselves, and they do look at the epidural side. Most of the time, they are here between 8 and 8:30. I usually wait for them instead of saving the patients twice, getting it up and,
And sometimes it's easier for these patients, instead of turning to their side, you can ask them, would you like to turn a little bit to your side for me to look at your epidural incision, or sit up in bed? And most of them will tell you they'd rather sit up in bed. So you could just have them lean forward and then look, you wanna assess that epidural incision site. And most of them will have a little bit of blood at the incision site, maybe a little bit of dampness under that tegaderm. But it should not be leaking, look red or swollen.
Cafe day 2, pretty much the activity, a lot of rest as well, and if they are determined, then the end of the, like in the afternoon and the evening time is really getting in, sitting up and dangle the feet, the edge of the bed. Some of them, they might just want it to sit up and change the linens. It's totally up to them. You can, tell if they are willing to do it. You can always have it and always change the mind, and accordingly you can make your own decisions. Incentive spirometer. Can you do that?
Yeah. So this is important initial post-op teaching. So as soon as they get into the room, which they're probably not going to remember. So then the next nurse that comes on will need to reinforce it, and they'll just need to kind of keep reinforcing it. But since this surgery is directly related to the chest and in the chest area, it's definitely important to have them do. And they're going to have pain, so you might need to pre-medicate them with this with a breakthrough dose if you're really working on the incentive spirometer, or medicate them afterwards as well. But you got to catch them if you medicate them so they don't fall asleep right away before you start working on this.
If you think actually that they were having a deflated lungs during a surgery, just that knowledge, and then the chest was this way, all of a sudden is here, more space and everything, that they, if they are not, and it's honestly, they are really breathing shallow breath, they are kind of protecting the chest because movement hurts. That way, that's where the fluids collection and everything, that they really trying, first of all, to increase the volume of the lungs, and the other thing, really prevent pneumonia, okay? How I said the shallow breath, it is actually important, even with that sunken chest what they are having, they are a tummy breather, most of them. Okay, now all of a sudden they need to learn actually totally new technique. That way they really need to take a breath throughout the chest to really expand those lungs to new capacity. That way that's what you are focusing to when you do the exercise with them. Are they doing by the, the tummy or really by the chest? Okay. That way, Dana, it's time to do the incentive spirometer. That's gonna be helping you to take a deep breath. You were asleep right now, and I can see you took a shallow breath. That way, what we would like to have 3 sets of 10. All right, let's go to 4 other directions. Okay, what I want you to do, just to make a nice seal with the mouth. Nice seal with the mouth, and you're gonna take a nice, slow, deep breath.
How many times do
No.
you have to do this?
10 times. Okay? That way, making a seal, take a nice, deep breath, and let it go. Only one for now.
You guys can't judge me.
Excellent! Yay! That's
Yay!
it! How is your pain?
It really hurts.
It really
Need
hurts.
more medication?
This one should not prevent us of doing. If you see the tears coming out, they can always stop. Give them the breakthrough of the morphine. And you come back in 10 minutes, but you really need to do the whole 10. Okay, at least to begin with.
They're supposed to really do 30 in an hour,
Yeah.
3
Yes.
sets of 10. So nursing care wise, and they're not patients that you can just go, here's your incentive spirometer, work on it. You
It's
really
gonna
have
be
to
at the bedside of when
help
you use it.
coach them and encourage them and keep explaining, this is helping you after surgery. This is for your benefit to keep you from getting pneumonia. And scare you know, let them know pneumonia is a complication and it can make you very sick and inhibit your recovery and make you feel terrible afterwards. So it's really important to work on it.
And just what Dana kind of modeled here happens very frequently is that they want to do like the short rapid